Okay, perfect. So I think we will go ahead and get started. Thanks for joining another session of the Virtual Global Spine. We have three guests with us today. Dr. Jain, Dr. O'Connor, and then Dr. Shaw will be joining us, sounds like any minute now. I think he might be finishing up in the OR. And we're going to start with Dr. Jain, who is my former partner here, who's now in Florida. I'm happy to have her on and really happy to hear what she's going to tell us about and have Dr. O'Connor weigh in as well and Dr. Shaw as well. And then anyone here, obviously put your comments in the comment bar if you have questions or comments or opinions. And Dr. Jain, I think I'll hand it over to you and we'll go from there.
Awesome. Thanks for having me, Dr. Goodwin. So I really appreciate your participation as well as that of Dr. O'Connor and Dr. Shaw. So I think Dr. Shaw is joining right now. So this is meant to be an interactive debate between various spine surgeons. And so what I think is super fun about this conversation is that hopefully, and I think this will end up happening, is that all of us would treat these problems somewhat differently. And so the purpose of this talk is really to highlight some of the variability that we have in spine surgery and get different opinions for what are actually just very common problems and are pretty I would call run-of-the-mill spine problems. So let me go ahead and get started, and then I'm going to pester some of the other faculty members with questions just about, what they would do. So this is a 67-year-old gentleman. He is actually my senior partner and an orthopedic surgeon. And he has a L4-5 degenerative spondylolisthesis that I think is fairly obvious on the x-rays on the lateral there. These are his flexion extension x-rays. And I think there is some amount of mobility. And then these are his MRI cuts. So what we can see is he got severe canal stenosis at L4, L5. And then he also has a cyst. It's probably a facet cyst originating from L4, L5. That's a little bit more caudal, but also causing neurologic compression. And so he presents with symptoms of severe neurogenic claudication and radiculopathy. So I'm going to pause there and then go down the line here with each one of our faculty members and ask them what each one of them would do in this situation. He has failed non-operative care, so we're talking primarily about surgical management now. So let me start out with Dr. O'Connor. What are your thoughts?
Yeah, so thanks. So as you mentioned, it looked like on the flexion extension, there is at least 3 millimeters of, mobility there, which would meet criteria for instability. It looks like there is neural compression and then evidence of a synovial cyst. So, what are the goals of surgery in this for this patient? Well, after failing conservative treatment, decompression, stabilization, and decompression of and restoration of alignment. So, I think this is a great case to show that really, I think all three approaches, both an ALIF or really ALIF, OLIF, lateral or posterior would all be great options for him. I think for him, I'd probably talk to him more about a MIS open TLIF. I tend to, if there's a synovial cyst, go in and resect the cyst. And then, in this case, just do a single stage T-lift. But that being said, the second option I'd also probably talk to him about would be an A-lift and then robotic perc screws. And I think either one of those, would be very, very reasonable for this patient.
So Dr. O'Connor, I'm going to follow up with some questions and then I'll move on to the other panelists here. So you mentioned that the instability that I showed on the flexion extension x-rays was important to you in your surgical decision making. How important is it, or maybe it's not, you just mentioned it and referenced it. Do you think that seeing that instability on flexion extension x-rays is really important? Let's say that it didn't move that much on flexion extension. Would you consider a decompressive only surgery?
Yeah, I would. I think a lot of people talk about fusion in the setting of synovial cyst, and I think that's probably the right thing to do. There was a good study that recently came out that looked at that very question, and they found that decompression alone, those patients did get relief, but there was significantly increased chance that you'll be back in the operating room within a year, with return of symptoms. So I actually give them the option. I let them know that, well, there is this cyst. Does indicate underlying instability. I can go and remove it. That's an outpatient surgery, or we can remove it and then stabilize that area. And some patients just say, you know what, I've heard about these screws and rods. I want nothing of it. I just want an outpatient surgery, want to go home the same day. In which case I say, you know what, I think that's okay. We can go ahead and try that and see how you do. And for those patients, I'd say probably 3 out of 4 of them do really well. But probably at least 25% of them come back within a year and then need follow-up stabilization.
Okay, great. And just to clarify, your approach would be a direct decompression in addition to an interbody fusion.
Correct.
Okay. So now I'm going to pick on Dr. Goodwin here. Dr. Goodwin, what would you do? How would you treat this patient? You're on mute, or I can't hear you.
What about now? Can you hear that?
Yeah.
Perfect. So first of all, great case. This is like such a classic thing to show, because there's so many things you can do here, and a lot of them I think are right. And so I think if this patient's indicated for surgery, has failed conservative treatment, there's a couple things I think Dr. O'Connor said, a lot of them actually. I would want to do a direct decompression. I would, it does look like there's a little bit of movement on those dynamic films, which oftentimes for degen spondies, you don't actually see that. And you do see that in this case. I think that with the facet cyst would make me lean towards decompressing and fusing it. Are you wrong if you say you want to try just decompressing it? I don't think you're wrong if you just try to decompress it. When it's a facet cyst, it's going to be a little, or it could be sticky, stuck to the dura. I like having good eyes on it, a good decompression of it, peeling it all off carefully. The one thing I would do, so what would I do? I do a 4-5 fusion. I do it all posterior. I would not do an inner body probably. You certainly could. One thing that I think very much about is alignment. And so if you do an inner body, you want to make sure you're not making them flat at 4-5. We're certainly learning more and more that even for these smaller degenerative cases, we want to think about their alignment, make sure we're not making people flat and setting them up for things down the road. That being said, if you're not going to do an inner body, then you need to pay attention to what you're going to do posterolaterally to get it to fuse. So if you're going to address the facet cyst, you may not want to take the whole facet off, right? You want to make sure you have at least some good posterior lateral bone, even if it's on one side. Use some BMP, but you want to make sure you can get it diffused at the same time.
Awesome. So I'm hearing from you open decompression and posterior fusion.
Correct. And then the only other thing I'll say is you just want to make sure you look at the 5-1 level too. I have had a couple in my life that have come back, and looking back on it, you go, that 5-1 disc looked pretty bad. I should have addressed it at the time, and I didn't. But this one seems like it's probably okay.
So I think that's a great point to make. This one, I didn't show the cuts, but there is no foraminal stenosis at L5S1. But to your point, I also have definitely been burned in the past. And having a 4-5 degen spondy with a collapsed disc and foraminal stenosis at L5S1 is just a super common picture. Okay, we have Dr. Shaw as well. Is that correct?
Hi, Deepti. Can you hear me okay?
I can.
Oh, perfect. I think this is a great case, and I will play the contrarian on this one. So I look at this case. Would you mind going back to your X-ray? And so I look at this, and I do see a grade 1 degen spondy. I am maybe not seeing quite the mobility that the others are talking about. I do see a little bit of flexion extension motion. I see minimal translation. I kind of almost more see optical illusion than anything else. I think if you're really going to put some numbers on this and measure it out, I think you're not going to see a lot of A to P translation. I also think you're not actually seeing a lot of angulation. So for me, I think about this. What would I want? I mean, that's how I view all the surgeries I do is, What do I want? And then also, what is my next surgery if this fails? Would you mind going to the next slide? So then I look at this and I'm kind of looking at the facets. These facets to me are pretty coronally oriented, and they're not very sagittally oriented. So I think that is a net positive. I'm not seeing a lot of either intrafacet fluid or a lot of dorsal facet cyst. I'm not seeing really severe facet arthrosis. Sure, there's some. I think that's pretty consistent with the patient's age. He's got pretty good disc height throughout, and I don't see a large disc herniation. So mostly what I'm seeing is this cyst. And I think that cyst can be resected pretty easily. I think if you were to get rid of the cyst, I would wager he would be pretty happy. He might need another surgery at some point in the future, but I think you've heard from the two prior folks who commented on this case that they're anticipating another surgery anyway at some point. So I think for me, I would probably recommend a less invasive decompression. And for me, that could be done mini open. If you're going to take the midline, that's certainly the easiest. But I would probably do this with a paramedian incision and a tube, and then you can decompress both sides.
So I'm so glad I showed this case because I asked 3 different spine surgeons and they all gave me 3 different answers, which is amazing. And I'm going to tell you, I did none of those things. I did a lateral interbody fusion with percutaneous screws and indirect decompression. So just goes to show how many different things we can do to treat the patient. And I think that all of the options are very, very appropriate. So I'll go back and maybe describe some of my reasoning. So I think, and Dr. O'Connor did mention this, I think that a facet cyst is indicative of instability. So I will personally always fuse a facet cyst with a degen spondy, primarily because I think it just indicates that I think it'll just recur if it's not fused. So that was my primary indication for fusion. I've also just been burned a number of times, you know, in the past where I try a decompression only on a degen spondy and then they come back to me 6 weeks, 3 months later. And they just have, you know, recurrence of their leg pain and recurrent stenosis. So I think I've been burned a few times. So that was my rationale for a fusion. And then I have found that indirect decompression really does work. I'm really hesitant to say this, but I've actually never had it fail for a lateral interbody fusion for this indication. I have had indirect decompression fail for other reasons. But I've actually been surprised that even despite having a facet cyst, that just giving a little bit more space for the nerves is usually sufficient to resolve their symptoms. I do always tell them that, you know, if I have to go back, we have to go back to take it out. But these can be stuck. Dr. Goodwin and Dr. O'Connor, I've worked with both of them very closely. They know how much I dislike direct decompression. And especially dissecting like a synovial cyst off the thecal sac. And I just really don't like CSF leaks. So that's why I chose an indirect decompression. And I've yet to have one fail for this indication. So far it's been good. I'm sure it'll happen eventually one day. So yeah, he did great. He did really well.
Well,
Which is good.
it looks really nice what you did. And when do you when you have these and you're doing something like this, what would make you do a direct decompression, or how do you kind of think about that?
Candidly, almost nothing. I can't remember the last time I had a degen spondy that I did a direct decompression. Now, that is not always 100% true if I'm doing an ALIF at 5-1. There's a spike sometimes that can come off off of the SAP, and that can really cause problems. And I've had that happen, and I've had to go back and do a direct decompression. I've had that happen with some amount of frequency, actually. Probably at least, I don't know, 4 or 5 times in my career, which is quite frequent, actually, I think. But yeah, I can't think of something I would see that would make me do a direct decompression.
And Dr. Shaw and O'Connor, when are you doing something like this, an indirect decompression only, or how do you? I mean, because for me, I'm so old school. I'm just you know, I worry too much. But you guys are probably more progressive than I am.
I mean, Matt, I do these with quite quite a bit of frequency as well. This is a great plan B surgery for me. I mean, that cyst will resorb. So that cyst is from that joint being angry for sure. No question. But if you resect it, which can be done pretty quickly and through a pretty small incision, they're going to do really well from that and probably get many years. If you do a direct decompression and it doesn't work, you can still do this. You haven't burned any bridges, you don't have any scar to go through. You can do, little Wilty posterior incisions and place screws percutaneously with navigation or robot or old school, and you can do a lateral interbody. But I think to say that, like, for me, this is not my go-to. This is 4-5. If you look at the position of the crest, I mean, deep D, this looks great. This case can go south in some ways as well. So if you look back at that psoas morphology, I think it's, amenable to, a trans psoa approach. I think it's amenable to an anterior to psoas approach. But I think if this patient who's your partner wakes up with a femoral palsy, oh my gosh, that's a huge problem.
I had a lot of anxiety before this case. This was probably my most anxiety provoking case I have ever done. Yes, and I like sent the pictures to multiples of my colleagues before I signed him up.
So Matt,
I'm so glad he did well.
yeah, it looks great, DT. To answer your question, it's a good one. A lot of times, especially if there is direct compression on the neural elements in addition to, some type of instability or spondy, I stage those. So I'll do some type of anterior column stabilization. So like, let's say an ALIF or expandable ALIF, and then I'll bring them back a day or two for the posterior. And so I'll ask them, before I go back in, hey, do you still have that radiculopathy or is it improved? And if they say, actually, my radiculopathy's gone, then I'll just do, posterior stabilization and hold off on direct decompression.
Okay, great. I think it was a great discussion. Thank you guys all for participating. So, Dr. Shaw, I know that you're giving another talk in a little bit. So I'll do this case and then maybe we'll stop after the second case. So
sounds perfect.
Yeah, this is another very, very common case. This is I think he was like in his late 60s, early 70-year-old guy with isthmic spondylolisthesis, L5S1. You can see that he has severe foraminal stenosis bilaterally at L5S1. He presented with L5 radiculopathy. And he's failed non-operative care. So let's talk about surgical management. And maybe I'll start backwards this time. I'll start with Dr. Shaw. Dr. Shaw, what would you do for this patient?
Deepti, this is another great case. I guess it's, Spondy Day in South Florida, but I think this for me is just absolutely screaming for an ALIF. I love anterior surgery. I think it works really well. Got to double check the vascular anatomy. We're a little bit out of plane with that axial. But I think this is one that's really amenable to indirect decompression from the front. I know there's some evidence to support standalone ALIF for isthmics. That's not really something that I do too much. That posterior there is, yeah, there is a movement. I'm not part of that movement, but but there is a movement for
I'm not either, in case that's not obvious.
And so I would back this up percutaneously, probably with pedicle screws at L5 and S1.
Okay, Dr. Goodwin, what would you do?
Can you show us the plain film again? I was distracted.
Yeah, and then just to reiterate, so Dr. Shaw said an ALIF followed by a posterior stabilization with percutaneous screws.
Yep. This is I'm probably not gonna stray too far from that. He's got L5 symptoms is what I'm hearing. And so I love an ALIF for this. I want to look at the pelvis and make sure we're amenable to getting there, but it looks like we can. So I would do an ALIF. I use an old school, like when you were here, I still use, and oh my gosh, your child is growing up. I still, as DP knows, I use a femoral ring allograft for my ALIFs, as originally taught to me by Mike Kelly. And I love the being able to cut it exactly how I want it. And this one I would not be too aggressive, right? I wouldn't want to cut it too big here because it's already so compressed. And then I would back it up. I'd probably do it the same day. Like Dr. O'Connor said, I like actually doing them on different days just because even the repositioning in that time where they're under anesthesia repositioning, I don't love. But typically the way we've done it is single level, I'll back it up that day. Um, and I might even get cute and do something with augmetics or a Wiltsy approach or something like that. But and I would probably just do 5-1. I know some people, depending on the degree of the isthmic spondy, might advocate for a bolt in the pelvis. I think for this, especially with an ALIF, you don't need to do that.
Excellent. So I'm hearing ALIF. Dr. Shaw, I presume that you would use a metal cage. Dr. Goodwin said that he would use a allograft ring. And Dr. Goodwin, you said that you would not stage this. Dr. Shaw, would you stage it? Would you do it on separate days or the same day?
Same day. The back is pretty fast. I do this either with fluoro, nav, robot in the back. It takes about half an hour, and then the patient will go home the next day, which they like, sometimes even the same day. So I definitely try and get it done in the same day. I find the patients do really well. I do really like 3D printed metal. I will use PEEK from time to time, but mostly metal.
And DP, how old is this patient?
I forget. I think he was like 70.
Oh, he's older. Okay.
Dr. O'Connor, what would you do?
Yeah, I think we're going to be all three for ALIFs here. So yeah, just like, Dr. Shaw and Dr. Goodwin have mentioned, I think for L5S1, it's a little bit of a different thought process here. There's a, more significant biomechanical force at the lumbar-sacral junction. So I think, that big inner body can be very helpful to prevent pseudoarthrosis. So usually if possible, I'll go for an ALIF here. And so, certainly for like a grade 1 or grade 2, I think that's a great option. So the only slight difference is I'd probably use a type of hyperlordotic expandable ALIF here to try to just get some restoration of the foraminal height as well, while keeping the end plates intact, and then stage, probably just with the robot, the next day.
And no one said a direct decompression? Or Dr. Goodwin, did you say a direct decompression? No?
Can we see that MRI again? You're probably not going to need to. Yeah, I don't know. I don't know what it's like. Yeah, so I think you're probably not going to need to, right? I think it kind of depends on what it all looks like, but I don't know that you necessarily would need to.
And then Dr. O'Connor, you said that you would stage it or you would do it on the same day?
I would stage it just because of that question. I'd say the majority of the time you really don't need to, just because of the indirect decompression there. If they said that they had ongoing radiculopathy, then I'd directly decompress as well. After the first part. Yeah.
So not surprisingly, I did an ALIF, like everyone else said. And then I put in percutaneous screws. I did stage this, and both of them were outpatient surgery. So I typically do 1-level ALIFs as an outpatient, and 1-level perc screws as an outpatient. And I think staging versus not staging is a very common question that comes up. Candidly, I don't think there's a right or a wrong. I stage them because I like the feedback. Granted, with an isthmic spondy, I think it's very unlikely because they don't usually have that spike. So I think it's very unlikely that they're going to have any persistent radiculopathy. But that being said, I still do stage them. And then, a lot of it has to do with kind of just like scheduling. I think most people use an approach surgeon for doing ALIFs. I think there are some people who don't, but for the most part, most spine surgeons do. I definitely do. And so a lot of times, I happen to work with a gentleman. He's an amazing surgeon, and he does most of the ALIF exposures in the Tri-County area, if not even further. So he's just very busy. So we try to stack our ALIFs all in one day, and so it's a lot of scheduling. So we'll do like 4 or 5 ALIFs in a day, and then I'll just back all of those patients up on a different day. But yeah, I agree with Dr. Shaw. I mean, it's a very quick thing to put in the screws in the back. It doesn't take long at all.
I mean, I will kind of say that there's one thing, especially with 5-1, especially with this, if we're really achieving the goals, which is to, place an inner body, get some indirect foraminal decompression, support that 5 body on the sacrum. I mean, we're going to lengthen that L5 nerve for sure. And it depends how big a graft you're going to put in there, especially you start using big stuff. You are going to get some traction radiculitis. I think for me, and you kind of talk about watching, but I don't really necessarily always know right away. Like if there is some leg pain, is that traction radiculitis? Is that spike that's been alluded to? Is there something else going on? And so for me, I think sometimes it takes a couple of days at minimum for that to settle out. And sometimes it can take even longer. So, I mean, I am relatively quick to re-image and double check, but I have a hard time telling what's a traction radiculitis versus something perhaps more sinister.
I think that's a great point that you bring up. It really highlights, and I think maybe Dr. Goodwin mentioned this, that this is really collapsed. You do not need a big cage here. You probably need the smallest, if you're using a cage, you probably need the smallest cage they make,
It,
which depending on the system is like a 10, 11,
I cannot agree more. Yeah, this is uh, exactly what both of you guys are saying, that it's so compressed. This is not a deformity correction. You're not trying to achieve some X goal of cranking it open to do something else. You're just trying to get a little decompression, not and still maintain some lordosis, get pressure off the nerve. I think the mistake would be to go really big here and get a foot drop or something like that, or just pain.
Yeah, I unfortunately learned that the hard way. I was putting in initially in my practice like very large cages just in general. And then one of my partners at the time was like, that's a really big cage. And I was like, oh, it is. That probably explains it. So, well, great. I'll stop there because I know that Dr. Shaw has some slides to share. But thank you for your participation.
They're great cases.
These are great cases. Matt, should I just go ahead and share my screen, or what's the best way to do this?
For sure. Yeah, that should work fine.
Okay. Let's see. Just 1 second, please. So we're going to change tunes pretty significantly. This is a little bit more didactic. And I mean, I think this is kind of dovetails nicely in the sense that this applies to all of us. This applies to the cases that we just talked about. This is really everything that we do currently, what the future looks like, and then more. And I talked to Dr. Goodwin just a couple of days ago, and he asked, what I wanted to talk about. And this is one of my favorite things to talk about. And I've been thinking an awful lot about this recently. So currently, I work at Intermountain Health in Salt Lake City. I have some research roles with them as well. I do have some relevant disclosures for this talk. So I talk about off-label use. I do have some intellectual property related to this. And then I do serve on a scientific advisory board for a company that makes technology related to this topic. And this is where I spend a lot of time. So, both clinically and academically, I think a lot about antibiotic stewardship. And there are 5 Ds to this. So you got to give the right drug, the right dose, the right drug route. You have to give the drugs for long enough, and then you have to stop them soon enough. And these goals are really about avoiding unnecessary antibiotic use, reducing adverse effects, as well as resistance. And then we have to balance this with both our individual patients as well as the broader population. And I am an orthopedic spine surgeon. I work in a large neuroscience group, and spine is not neurosurgery. Spine is not orthopedic. Spine has its own unique stuff. So the cranial infection profile is very different than the spine infection profile. The spine infection profile is very different than the broader general ortho infection profile. So the rate of spine infection after surgery ranges somewhere between 0 and 20%. So Dr. Goodwin does really, really big, huge, complex surgery on tumor patients, and they have a high infection rate. Traumas have high infection rates. Deformities have high infection rates. But then we take that and we look at endoscopic discectomy, which has a very low infection rate. And those are fundamentally very different things. And so spine is this really huge spectrum of procedures and a wide spectrum of anatomy. So cervical is not the same as lumbopelvic. And we don't really have this culture in spine of PJI, so periprosthetic joint infection. There's this real culture in parts of orthopedics, this awareness of infection, this awareness of infection prevention, diagnosis, treatment, and then almost treating infection as this scourge to be eradicated like cancer. And that really has not developed in spine for whatever reason. I'll give one HARP to prevention, which is always the easiest treatment. It is just so much easier to prevent a problem than it is to treat it after the fact. You can manage and mitigate so many host issues, especially for elective cases. Obviously, for tumors, you can't always do this. For traumas, we can't always predict who's going to get injured. But diabetes, nicotine, substance abuse, immunocompromise, a lot of these things are modifiable to some extent and really should be if we can. The rate of infection, broadly speaking, is roughly proportional to surgical invasiveness. So this is a huge surgery, and this is a huge complication if it gets infected. And so we need to really tailor what we're doing to prevent these infections to the procedure. And I don't really think we're doing that. So if you look at what the recommendations are for current antimicrobial prophylaxis at the time of surgery, the society recommendations honestly are quite vague. That's not throwing stones. This is NAS recommendation, last updated in 2013, so about 10 years ago. And they recommend a single dose pre-op of antibiotic and not really recommending a single drug. But they do say you should probably redose it after a few hours. If you have more blood loss, you should probably redose it sooner. You might want to consider some gram-negative coverage depending on the complexity of the case. But this has been very loosely interpreted to be cefazolin for everyone. Now, if you look at what we're actually trying to prevent, we're trying to prevent staph infections, both methicillin sensitive and resistant, staph epi, aerobic strep, and that's a lot of the stuff that lives in the skin. These are our very common things that are, all over everyone's body and commonly cause infection. You're going to move into less common things. So anaerobic cocci, gram-negative rods, other organisms. And then in particular, I will highlight C. acnes, which is particularly problematic and indolent in its course, shows up pretty late, commonly in things like pseudarthrosis and failed back surgeries. So what are most people doing for surgical prophylaxis? Mostly single drug. Cefazolin is weight-based. A lot of people are getting 1 gram, 2 grams, 3 grams, depending on the size of your patients. This is very important to dose appropriate to weight, and a lot of people actually are underdosed. I'll come back to that. Vancomycin and clindamycin are commonly dosed as single drugs in patients with the cephalosporin allergy. The necessity of that is somewhat debatable. These are used commonly, and then you're also going to have some people doing these combination drug protocols, commonly, let's say, with revisions. This is largely derivative from the arthroplasty literature, using maybe cefazolin and vancomycin. I touched on this briefly just a second ago, but this is a pretty good study put out in 2022, looks at the efficacy of cefazolin. And I would tell you that what this study shows, from my interpretation, is that cefazolin alone is probably not a solution for everyone. Cefazolin is commonly dosed as a 1 gram dose. That's not enough by weight for a lot of patients. If you look at the chart on the side of the screen, you'll see that there's a much broader therapeutic range when you're going to give a 2 gram dose. There's not a lot of toxicity associated with cefazolin. So really, you're not doing a lot of harm by overdosing, but we probably are doing harm by underdosing. When you think critically about these cephalosporins, they're great drugs. They're very effective about non-resistant skin flora. However, they're not going to address MRSA, other resistant organisms, and they're definitely not going to address gram-negatives. So there are some real holes in that coverage, and we're also not going to prevent a polymicrobial situation. When you look at vancomycin and clindamycin alone, these are really not great solutions either. And these are retrospective studies, Spine 2024. There's a PED study that's a little bit older. But each of these studies essentially found that vancomycin and clindamycin alone as monodrug prophylaxis actually are independent risk factors associated with surgical site infection and are particularly worse than cefazolin. So if you're going to pick one drug alone, cefazolin is probably better. But this is where I'm kind of going with this, is maybe one drug prophylaxis is not right for all spine surgery. The literature, I think, is supporting this, and this is a study that's now about 10 years old, published in Spine. It's a retrospective review of about 7,500 cases. And kind of what I've been saying, these staph are the bulk of infections. So skin, flora, staph, and strep are going to make up the bulk of infections. However, when you start looking at revisions, when you start looking at cases going down to the pelvis, you're going to have a much higher proportion of organisms that are not really covered. So up to about a third of those infections are going to be methicillin resistant. The cefazolin will not prophylax for those. And also for these lumbosacral cases, about a third of surgical site infections are going to be from gram negatives. And you're going to see a lot of gram negatives and enteric flora as you get lower on the spine. Now, this anatomic gradient that I'm talking about, which is really looking at cervical and saying cervical is not the same as lumbar and the bugs are different. This is a great paper. There are not a lot of studies like this. This was, I think, out of Seattle, and it shows that you're going to have a lot more gram-positive flora in the cervical area causing surgical site infection, and you're going to have this increasing rate of gram-negative and enteric as we get lower in the spine. And I think this is a pretty neat chart. So on this axis here, you're going to have cervical on the left, you're going to have lumbar and pelvis on the right, and then you're going to have this proportion of gram positive versus gram negative. And I think this tells part of the story. I think you're also going to have this situation where the actual patient's microbiome, and to some extent, the microbiome of the people around the patient, right, in the facility itself, but really the patient is going to drive what they may ultimately become infected with after surgery. And that's part of what we need to start to consider. So this is a newer study, and it was looking at the origins of surgical site infections. And it was actually pretty scary in the sense that the authors identified that nearly 90% of organisms in surgical site infection were endogenous strains from that patient. And perhaps scarier still is that about 60% of those isolates were resistant to the prophylactic antibiotic given. So what this is telling me is we are really, as a field, not doing a great job with our prophylaxis at preventing surgical site infection, and there is probably a lot of room for improvement. So where is all this going? This is going in a direction of probably specific drug regimens to tailor for the surgeries that we're doing. We need to kind of right size the drugs that we're using to prevent infection. So we're going to look at the location of the surgery. Is that cervical? Is that lumbopelvic? Is it more complex? Is it less complex? Is this going to be a primary procedure or revision? We got to look at the patient. Did this patient previously have an MRSA infection? If we're looking at a hospital, is this a hospital system or a hospital facility that has a higher proportion of things like MRSA, because that may necessitate different coverage? And then lastly, is there something else funky that we need to worry about? Are we worried about an atypical organism? Are we worried about something else? And so ultimately where I think this is probably going is these combination regimens, things like cefazolin plus gentamicin. You're going to get really great broad gram-positive coverage with the cefazolin. You're going to get some good gram-negative coverage with the gentamicin. And then that may be a good option for a primary case going down to the pelvis, for example. When you're going to do a revision, maybe you're going to want to add some vancomycin to that cefazolin. And if you're doing something that's kind of complicated, like a long lumbopelvic reconstruction going up into the thoracic spine, this patient's had 3 or 4 prior spine surgeries. These are common cases in this country at this point. You might want to talk about something a little bit more complex still, where that patient is going to get cefazolin and vancomycin pre-op. That case is going down to the pelvis, and maybe you're going to get cefazolin and gentamicin post-op or something like that. So this is kind of a newer concept, I think, in spine. It's been borne out in the literature a little bit in the last few years. This is actually the protocol that I'm doing for my complex cases in yellow. And so for like a bigger case that's a multiply revised patient, they're going to get ultimately 3 drugs as part of this prophylactic protocol. Now, is this perfect? Not necessarily. How long do you really continue this? The literature does not offer a huge amount of guidance on this. There's not a lot of evidence. There's not a lot of evidence to support post-op use. There's not a lot of evidence to say you have to continue this with the drain, or even that stopping before the drain is out is particularly beneficial. That said, I think with relatively short regimens, there's not necessarily going to be a lot of harm either. So this is a study, 2020, JBJS, looked at patients receiving prophylaxis versus no prophylaxis, and there wasn't really any difference in surgical site infection rate, but also not a lot of harm done with either C. diff or creation of these multi-drug resistant organisms. So the literature in general is pretty mixed. Now, so what's kind of like the next evolution in this as we adapt our protocols? I think we're going to talk about prophylactic local antibiotic delivery. Now, local antibiotic delivery is getting the right drug to the right place, so it really checks a lot of these Ds off. It's this great idea, and parenteral antibiotics are nice, but you're really giving antibiotic everywhere. Local is, I think, kind of the dream. Now, if you look at where this concept really originated, it was in the 1960s and 1970s in arthroplasty, and they were putting antibiotic in bone cement. And that's kind of the original descriptions. This took off in spine with vancomycin powder in the 2000s, which I think really became mainstream by 2010s. This was largely driven by some literature that came out in spine 2011. There were some early publications, and there were reports of these really remarkable reductions in surgical site infection. So I think this ushered in a new era of in-wound vanco. This then kind of morphed into in-wound TOBRA as well. And the benefits are quite obvious. Local concentration, which is high, systemic toxicity is low because you're not having as much systemic diffusion. Hits a lot of these Ds, like I mentioned, but I don't really know if it works. There's a new systematic review just came out in Core last year, meta-analysis of spine randomized controlled trials, no difference in deep SSI with or without in-wound vanco. There was a similar study, not quite as high quality, World Neurosurgery last year also looked at TOBRA, relatively similar conclusion. So for me, what the data is kind of saying is the powder alone is probably not the answer. And I myself have moved into this post in-wound vanco era. So I don't do it anymore, even for big cases. I just don't think it works. And I think part of that is this very rapid decrease in the concentration, and you're going to see the level drop off pretty quickly. I think the initial thought was that it sterilized the wound and then, decreased over time, which was okay. But you really are going to want something that sticks around a little bit longer. When we start looking at new technologies and new techniques that are coming out in the development pipeline, when you look at randomized controlled trials, you take a quick look at clinicaltrials.gov, there is not a lot new that is spine specific. But I think if you start to cast a wider net and you look at what other people are doing in general surgery, plastic surgery, parts of neurosurgery, other parts of orthopedics, and you start to see, hey, these are things that will probably make their way to spine in the near future. This is ultimately where I see prophylaxis and actually treatment going. So the next gen is going to be local drug delivery that can maintain an elevated drug level, lower systemic toxicity, something probably a little more refined than just dumping crude powder in a wound. That may have some controlled release characteristics. It may have the ability to perfuse. So, kind of put fluid in. You may have something that's inflow and an outflow. You're going to have some combination devices that are going to be a combination of a thing plus a drug. And there are a few things like this, in development with the FDA. Now you're going to say, hey, these things already exist. We have calcium sulfate. I don't know that this is the answer either. Calcium sulfate is this versatile thing. It's nice. It's semi-structural. You can make beads. You can make spacers. It doesn't need to be removed, but it can be. I think there's some definite downsides to it as well. You can put a lot of antibiotic in this, but the more antibiotic you mix with the cement, you reduce the structural properties, and you can end up with a pretty high osmotic load. So you can get wound drainage from this. There's also this other study that just came out. This was published in Biofilm just this year. And this is a study that actually says that this calcium sulfate cement will stick around after the antibiotic is gone, and in certain cases can actually become a nidus of infection to reseed that space with the same infection. So I think for me, unless you're taking these beads out, I don't know that calcium sulfate is really where I am with this. I don't know that it solves a problem much better than PMMA. Now, PMMA is nice. It is very structural. I think the structural properties are in many cases superior to calcium sulfate. This is not resorbed. This can be a permanent thing, or it can be taken out. I've put in spacers. I've put in beads on a string. I have left structural cement in cases of osteomyelitis discitis where I need some support and don't have a good other solution. But I don't love this either. So you are again placing something in there that can become a nidus of infection and subsequently reseed infection. So I think the future is kind of the evolution of all of these things. So there are these second generation calcium-based products. I have no financial involvement in this, but this is calcium-based. This is a current RCT that's rolling out in the joint space. I think they're pretty good applications for spine. So this is essentially a controlled release product with tobramycin. So I think the promise is that there's some structural property, you're going to be able to fill a bone void, and then you're also going to be able to have high dose controlled release tobramycin, which I think is pretty appealing. I would imagine that this could be done similarly with vancomycin or other drugs. I think this product is pretty neat also. So this is something put out by Osteal Therapeutics. There is no spine derivative product, but this is designed for revision arthroplasty at this point. And so this is a combination device, meaning that you're going to place a static spacer. This is a salvage mechanism for periprosthetic joint infection. You're going to place this static drug-eluting spacer for a defined period of time, which is going to theoretically sterilize that wound. There is a structural component to it. You're going to run fluid through it, which is going to diffuse into the wound space. And then this is commonly paired with a wound vac. So I don't know that this is an endpoint either, but if you start looking at what this company is doing, it's not hard to imagine a world in which we're perfusing our spinal implants with antibiotic. So I think that's kind of neat and will probably happen at some point in the future too. There are some simpler devices too, which I do think are also a more near-term solution to this problem. I don't know that this is an endpoint either, but this is, for example, a simple diffusion pouch that could be placed in a wound space. This is ideally designed for extremities, but I think the applications for spine are pretty clear. You could place this pouch, you infuse it with tobramycin, for example, and you're going to get your high-dose release. The advantage of a device like this is it can be placed percutaneously. It can also be pulled without a secondary surgery. So when I look at the future of antibiotics and spine and what we're doing, I think that there's a lot of room for improvement. Now, there is also a lot of room for improvement with just kind of doing a better job with all the nuts and bolts of what we do every day. So there are ways to minimize and reduce surgical site infection without antibiotics, just meticulous surgery, meticulous skin prep, multiple washes. So I do scrub all my patients with soap. I then give them all cleaning with alcohol and then do my secondary prep with iodine and alcohol scrub. Chlorhexidine if there's an allergy. I'll change gloves very frequently. I irrigate regularly. Some of that irrigation is saline. Some of that has things like chlorhexidine or dilute iodine in there, which there are commercial products for that, which can reduce surgical site infection. I do try and minimize OR traffic. I delay and minimize opening implants, and then particularly always handle those implants with clean gloves. So both myself and anyone in my room will handle implants with clean gloves. I avoid flash sterilization like the plague, and definitely should never do it for implants. And then lastly, I think you can consider VACs, which can reduce tension on that wound and really will get you out of a lot of jams. And these are things that don't require any antibiotic use at all, but are just kind of good practice options. So in general, I think that there's a lot of room for improvement for prevention and prophylaxis. I do think that if you get an infection, the way you treat that is very similar to how you prevent it. You're going to reduce the amount of bacterial burden in that wound. You're going to debride that. You're going to take out hardware if you need to. And then for treatment, your antibiotic therapy really should not be empiric unless there's a clear threat to life, systemic sepsis, or something like that. And that broad spectrum antibiotic should be of relatively short duration and then narrowed based on cultures. I think you have a lot of local options for delivery that are going to come out in the next couple of years. And then these adjuncts, I think, are very helpful as well. So I'm pretty excited about our opportunities to improve and refine these kind of tried and true things that we've relied on for years. And I think that we're going to see a lot of changes in this space in the next 3 to 5 years. That's all I got. I'm happy to take questions and comments.
Oh, I got lots of questions.
So
I think anyone that says this paper was just published in Biofilm, a journal I did not even know existed, I should probably be listening to. So I guess I have a lot of questions, but I'll just ask one and let other people ask too. In cases where you cannot, you're going to say you can always remove everything, but let's say you can't really remove everything. Let's say it's a longer case that got a bigger deformity case got infected. And for whatever reason, you decide you can't really remove the stuff, but you're worried about long-term things, and you suggest they go on after they get treated, they go on oral suppression. What's your opinion on oral suppression? and lifelong oral suppression, and that concept?
I mean, Matt, that's a great question. So you are correct. I will tell you, you can always take the hard way out. I can give a whole talk on that some other time. I actually have. It's titled "You Can Always Take the Hard Way Out."
Wait,
And-
really?
oh yeah, oh yeah.
My question was the same as
I
Matt's.
love it. I love it.
So I think we have this paradigm in spine where we've said we can't always take the hard route, and I don't always think it's easy, and I don't always think it's a good idea. But I would tell you, pretty much, you can always take it out if you need to. And the problem is, you have to look at who's getting these infections. A lot of people who are getting surgical site infections, particularly deep SSI in spine surgery, we largely have a host problem. That host is malnourished. That host is not otherwise optimized. And their ability to clear that infection is very difficult. It's like cancer. This is an uphill battle. And you can throw pretty much unlimited antibiotic at it, and you can work on this stuff, but in some cases, these infections are going to establish a biofilm in that wound space. We know from basic science that that happens really pretty quickly, probably hours to days. This is not a weeks to months thing. So you have these wounds with biofilm, you can throw antibiotic at it, and unless you can make some headway with that host, it's really difficult. You have to find a way to reduce that bioburden. The easiest way to do that is to take out the implants. When you look at the joints literature, it is full of all these crazy acronyms. They have DARE, they have double DARE, they have these one stage, they have all these two-stage exchanges. They will do these multi-stage exchanges. And we actually do all the same stuff in spine. So I will do, a debridement with implant retention, which is what DARE is. You can do that twice. That's double DARE. You can do a single stage exchange. You can essentially do your surgery, take everything out, close the whole patient, tear everything down. You can move to another room. That's a true single stage exchange. And then you put it all back in. So you can take all the hardware out, you can put it back in. You can stage that. So you can take all the hardware out. You can then do a secondary debridement. You can do a third debridement. You can put it back in. You can do that, and you can add things like KCI makes this wonderful lavaging vac, which will wash your wound with Dakins. So you can put a drain in, you could put this sponge in, you can run Dakins through that wound for a couple of days, and you can take the patient back. And so for me, I'm going to really try and manage that infection very aggressively, primarily, if I can. That long-term antibiotic prophylaxis piece that you mentioned is the next step. You got to get them through the first step, which is the debridement piece. It is the antibiotic piece, which should be driven by the culture. You almost always should be able to get a bug. It should be a pretty rare thing. You can use a variety of molecular genomic techniques. There's a multiplex PCR, there's next-gen sequencing. We have all that stuff available to us. You kind of have to ask for it. But at pretty much every facility, you should have some element of that, even if it's a send out. And you may not get those results for a few days or even a couple of weeks, but ultimately you should be able to end up on the right drug. And then that can lead into your prophylaxis, your suppression prophylaxis piece. Now, I've been talking for a minute, but I think that there is a role for oral suppression. I think that suppression is really important. It does need to be bug specific, but I don't know anybody who could do anything indefinitely. So I think realistically, I shoot for about a year, and that's typically what I'll try and get. Sorry, that's a really long answer.
Well, that's you kind of answered my question at the end there. So then you tell them what they can come off and let's see how it goes, or what?
Yeah, I think this is something where you need to have a team. So you need to have a trusted ID colleague, or ideally a team of MSK, typically ID folks who are familiar with bone, joint, and spine infections. That's typically who will manage these. And then you need to have some surveillance. So that surveillance is typically monitoring of any inflammatory markers. You're going to have to look at electrolytes. These drugs do have systemic effects. Some can have some nephrotoxicity. And then you also are going to maybe want to do some surveillance MRI. So see if something's going to pop up. Can be a little tricky if you got a lot of metal in there.
Well, it's interesting to hear that, because I've had several that over the years that have come off their antibiotics for different reasons that I didn't want them to, and they ended up kind of being fine. And I thought they would have needed to stay on that. And so it just shows that I don't really understand it, probably.
I don't think so at all. But I think it's just a tough problem, you know? I mean, this is a really, it's a tough problem. And I think that we as a field are, you know, not that advanced yet.
All right, well, I'm going to ask one more since we don't have another question. So, your personal preference now for drains and post-op is what? Keep the
Uh,
antibiotics on for 24 hours, keep the antibiotics on where the drains are in, depends on complexity of the case.
Yeah, so I am keeping drain antibiotic on a little longer than I used to. I think I used to be slightly more literature based in this, and the literature said it didn't matter, so I stopped the antibiotic. I increasingly have kept the antibiotic on a little bit longer. With use of gentamicin, there are some toxicity concerns, so you do need to check a trough if you're going to run it longer than a couple of doses. So right now, it's a balancing act with pharmacy where I can usually get away with 2 or 3 doses of Gent, which I think is most of what I need, which will get me a couple of days. And then I'm usually going to do Ansef until the drains are out at this point.
And then are you getting pushback from ID for adding Gent afterwards or no? I mean, because you showed the data yourself and said, well, there's no good data for some of this.
I am not getting a lot of pushback, actually surprisingly little. I thought I would get more. And then I showed them the literature. And I think if you look at this literature and what some of these papers are recommending, I would really look at those 2 articles by Long that I showed in my talk. I would read them. They're kind of interesting. They're unique papers that have a little bit of a contrarian perspective that really made a lot of sense to me. They recommend, at least in the first one, adding gentamicin. I think you could probably make a case for tobramycin as well. So Gent and Tobra, similar, a very similar structure. They have some side chain differences. They're going to function relatively similarly. You could make a case for one or the other. I don't think there's a huge difference. Honestly, their coverage is relatively similar. I've had more pushback with tobramycin from pharmacy than gentamicin for whatever reason.
I wonder why that is.
I think it's viewed as like a bigger gun.
I see. All right. Well, that's pretty fascinating. I would have thought they would have been coming after you for creating super bugs or telling you to tone down a little, but it's not, but you did show some compelling data. So,
I mean, I guess what are your thoughts, Matt? You do a lot of big surgery. I mean, what infections are you seeing?
well, that's correct. And I don't have a good rule actually. So I will oftentimes like to keep antibiotics on while the drains stay in. That being said, we have some patients who get complex plastics closures, and oftentimes plastics, you know, doesn't want antibiotics or says like no antibiotics, and we have to say, well, where exactly is that drain? Is it deep? And maybe we do want to do antibiotics while that's still there. Uh, I spent some time in India. They never had antibiotics while the drain was in, and you know, I'm not sure things were that different. So I don't have a hard and fast rule. I feel better having them on for while the drains are in for some of the bigger complex cases, but I don't have, the data to back that up.
Yeah. I mean, I'm not talking about 6 weeks, Matt. I mean, I'm pulling most of these drains
Yeah,
with
I think we're saying the
a
same thing. I'm
day.
talking about in-house in the hospital. Yeah,
I mean, I have done cases with plastic surgery collaboration where I've had drains in for 2, 3, 4, 5, 6 weeks. I think that's a different situation.
agreed.
That said, I have also had more than one case where those drains have become colonized, and that is a big problem. Then you have this inside out infection, and there was not always a happy ending with those. And that's deferring to plastic surgery recommendations for no antibiotics. So might that have been different had we put that patient on some doxycycline, which is pretty broad coverage. It's not so toxic, tolerated pretty well. I don't know. Is we follow the best practice, but there's not always a good solution. I'd be curious what Dr. O'Connor and Dr. Jain think too.
Well, I mean, so I think your comment about patient host is really, really important. So, I mean, I have like very vastly different practices when I was at WashU versus now, I'm in private practice. So, I do almost exclusively ACDFs and MIS surgery now. And so you commented on the host. I would also add MIS surgery, it's just so rare to get infected. So in the past 2 years, I have had one anterior infection. I did a lateral and the posterior did not get infected, but the anterior did. And the anterior had some weird mycobacterium infection. It was very strange. I was thinking about when you said you can always take the hardware out. I mean, yeah, sure, it could probably be done. I probably could have gone back in and taken out that cage anteriorly, but I mean, I just feel like that's very risky, right? Going back into the retroperitoneum, moving vessels potentially, like everything's stuck, there's a ureter, like that is not a good idea. And
It's a bigger
so,
incision when I go back.
well, yeah, well, I don't know if that's going to help you with the vessels and like moving them if they're stuck. So, anyway, so that patient, like she did not go back to the OR. There was really no abscess. There was a small abscess, but it was more a matter of like if we wanted to take out the cage. And yeah, I mean, it was probably like she didn't do very well. I mean, she's fine now, like, or her infection's treated, but yeah, no, I've been really alerted to the MRSA issue, and so I do give all my patients get Ancef and Vanc pre-op. I'm very interested. I don't actually give post-op antibiotics in general, mainly because I do a lot of outpatient surgery, and my patients usually go home. I have some colleagues who do a lot of outpatient surgery and they do oral antibiotics and they'll send the patients home for like a week. I don't know if you would know better than me if there's any evidence around that. Probably not. Maybe it makes them feel better. But yeah, so I think like host and surgical technique are just, I'm with the exception of when I do cases with Dr. O'Connor where we do quite a few T4 to pelvises. For the most part, like I'm doing almost exclusively MIS surgery. So it's just really rare that they get infected.
Yeah, I agree. I think definitely that, our practice is maybe a little bit different than some of the bigger academic centers where you're doing like a, T4 to pelvis every week.
Although I will just highlight Dr. O'Connor does a lot of crazy cases.
Yeah, we do some fun cases together. I think I do a couple things that I think might be helpful. One is like for all big cases, prophylactic complex plastic surgery closure with like paraspinal flaps seems to be very helpful. I don't use PEEK. I just use titanium for everything just because of that biofilm, propensity for, especially for interbodies that can be actually quite lethal. I remember a few years ago when I was up in New York. I mean, we had a patient who died. She had a terrible infection, and no matter what, we did, she had peak interbodies from long before, and the infection just kept coming back and back, and then she'd get proximal junctional kyphosis and failure. We'd have to extend her up. She'd still be infected. It was just impossible. Like you said, I mean, it's almost like an oncologic disease where you're just trying to treat this and it just keeps coming back despite remission of potentially months. So yeah, I think just trying to do everything you can from a preoperative standpoint of making sure the patients are as healthy as possible. Um, Having plaque sticks close any big cases, using, all titanium. There is some interesting like new technology out there. So for neurosurgery, like for intracranial abscesses, ventriculitis, there's something called Iroflow that is, it's an external ventricular drain, but it also irrigates within the drain itself to help clear out, blood for intraventricular hemorrhage. And so I've used that for infection. I know the CEO of that company is interested for like spinal applications. So, like Dr. Shaw, like you mentioned before, like there's some newer potential technology for kind of actively, putting in antibiotics into that space and then flushing it out. I think that has some promise. So hopefully, there's newer potential technologies out there that could address this issue and help those patients that, especially those very sick patients that need it.
Well, I want to thank, looks like I didn't do a very good job of the timing. We're a few minutes over. So I want to thank Dr. Jain, Dr. Shaw, and Dr. O'Connor. That was a fantastic session. I am always learning from from you. And so thanks for all three of you coming on here and presenting and going through some of this. And I'm sure there's going to be more to come from all of you in the future. So thank you again. I think we'll end it there. Nice job.
Thank you for the invitation.
Yeah, Matt, thanks for the invitation. Thank you all.
Thank you.